everyone, my name is Lyndi Bailey, and in this educational presentation, I will be discussing the implementation of different preceptor teaching tools to enhance learning in the clinical environment. Learning goals. From this quality improvement project, you will discuss adult learning principles, the 1-minute preceptor, and the SNAPS teaching tool. You will understand the difference between the 1-minute preceptor and the SNAPS teaching tool. You will identify the best teaching tool to enhance rRNA learning/sRNA learning in the clinical setting, and describe how each teaching tool can be used to promote learning and critical thinking skills. Background. The use of preceptorship in the healthcare setting dates back to the 1940s. During this time, a man by the name of J.W. Morgan researched the use of preceptorship in clinical education of medical students and its effect on students' educational process. The results of this study emphasized the importance of developing an effective teaching and learning environment. Furthermore, the study concluded that the development of a positive learning environment must bring together the teacher, the patient, the nurse, and the student in a favorable environment for everyone. Since then, many other medical professions have adopted the use of preceptorship, for example, undergraduate and graduate nursing. The purpose of preceptorship is to augment student learning, provide opportunities for hands-on experience, allow students to demonstrate competence of job-specific skills, advance critical thinking, and build the confidence of the preceptee. Overall, research has shown a linear relationship between superior preceptorship and enhanced preceptee independence and clinical judgment. So what this means is that the better preceptorship that a student gets, the more independence and clinical judgment they will have. Problem identification. cRNA preceptors have the critical task of transferring high-quality patient care and patient safety skills to their preceptee. However, there are several problems with the current cRNA to sRNA preceptorship education model. First, cRNAs have minimal exposure to adult learning principles or experience in educational theory. Second, cRNAs do not receive formal training to precept rRNAs. Third, a formal preceptor/preceptee teaching tool is not being used in the clinical setting. Finally, rRNAs encounter negative clinical experiences that prevent them from learning and growing as clinicians. Due to these problems, this quality improvement project looks at different preceptor teaching tools that can be used in the clinical setting in order to enhance preceptor teaching skills and promote learning and critical thinking among preceptees. Proposed intervention. In this quality improvement project, the proposed intervention is the implementation of a preceptor teaching tool in the clinical environment. The use of a formal teaching tool by all preceptors can decrease teaching discrepancies, stimulate critical thinking skills among preceptees, foster increased preceptor to preceptee communication, endorse active learning among the preceptee, boost student/resident engagement in clinical decision-making processes, and encourage preceptor to preceptee feedback. Adult learning. Studies have shown that adults learn better when they participate in active learning. Active learning emerged in the 1960s and is a teaching learning strategy based on problematization to reach and motivate a student through keen involvement in their training. The learning outcomes of active learning include analyzing, creating, and evaluating. There are 3 determinants to learning. First is the need of the learner. This is the knowledge gap between the desired performance level of the preceptee and the actual performance level of the preceptee. The second is the state of readiness to learn. This is if the preceptee is demonstrating interest in learning information and increasing clinical knowledge and skills, or are they not? The third is the preferred learning style for processing and learning information. Studies have shown that most adult learners need a combination of learning techniques. So this means to the right that adult learners need learning techniques that are in the cross-section of these circles. SNAPS. SNAPS is a 6-step mnemonic based on a learner-centered model that encourages clinical reasoning and development. The S stands for summarize briefly the history and physical findings. The N stands for narrow the differential diagnosis to 2 or 3 relative possibilities. The A stands for analyze the differential by comparing and contrasting the possibilities. The P stands for probe the preceptor by asking questions about any uncertainties, difficulties, or alternate approaches. The second P stands for plan management for the patient's problems. And the S is select a case-related issue for self-directed learning. This model can be incorporated into the CRNA to SRNA clinical education model. The way this can be done is that the preceptor can go through this model with the preceptee preoperatively to organize an appropriate anesthetic plan. This model can also be used intraoperatively when complications occur that need to be quickly identified and addressed appropriately. After assessing many different studies on the SNAPS teaching model, 5 main findings were consistently found. The first is that SNAPS teaching tool is a 6-step model that provides residents with a systematic approach to transition from directed learning in the classroom to self-regulated learning in the clinical environment. Second, the students were more concise when providing patient summaries and spent more time discussing clinical reasoning related to patient management than their counterparts who did not use the SNAPS model. Third, students who use the SNAPS model were more likely to bring up uncertainties about treating or managing a patient's care. Fourth, students who use the SNAPS model were more likely to ask questions about their uncertainties to their preceptors. And finally, after using the SNAPS model, it was found that the SNAPS model increases practical clinical reasoning skills, self-directed learning, and clinical learning. 1-minute preceptor. The 1-minute preceptor is a 5 microskill model that provides preceptors with a basic teaching framework for the clinical setting. The 5 microskills within this model are get a commitment, probe for supporting evidence, teach general rules, reinforce what was done right, and correct mistakes. After assessing many different studies on the 1-minute preceptor model, 5 main findings were consistently found. First is that the 1-minute preceptor model is a framework that provides efficient and precise preceptorship, which enables learning in a limited time due to patient care demands. Second, the 1-minute preceptor model shifts teaching points away from generic skills towards disease-specific and patient-specific teaching. Third, the use of the 1-minute preceptor by novice educators may increase student learning. Fourth, using the 1-minute preceptor moderately improves teaching skills and promotes positive teaching behaviors. Finally, when the 1-minute preceptor was used, there were increases in formative feedback to residents from preceptors, student/resident engagement in decision-making process, increase in student/resident clinical learning, an increase in student/resident motivation to do outside self-learning, and an increase in student/resident satisfaction with their preceptor's teaching. This slide, you can see the teaching tools overview comparing the 1-minute preceptor model to the SNAPS model. Overall, it's the same information that I presented above, but in chart form. Comparing the two teaching tools. First, SNAPS is more student-led, whereas the 1-minute preceptor is more preceptor-led. SNAPS takes longer, whereas the 1-minute preceptor is shorter. The SNAPS model is best used during case presentations, whereas the 1-minute preceptor is best used in limited time learning environments. Both the SNAPS and the 1-minute preceptor increase both clinical learning and self-directed learning. SNAPS was better at allowing students to ask questions to their preceptors. However, the 1-minute preceptor is better at increasing formative feedback by preceptors to preceptees. Take-home points. I have 3 main take-home points for you all. The first is that the SNAPS teaching tool is a 6-step model that provides residents with a systematic approach to transition from directed learning in the classroom to self-regulated learning in the clinical environment. The second is that the 1-minute preceptor teaching tool consists of 5 micro skills that provides preceptors with a basic teaching framework that is efficient, precise, and cultivates a teaching to learn environment in the clinical setting. The third take-home point is that both teaching tools have shown to provide students/residents with an active learning environment. This learning environment enhances critical thinking skills, clinical learning, and at-home self-directed learning. References. Listed below are all the studies that were used to gather information that was presented throughout this educational module.